is this actually a feasible tool to use within this population? Can we adapt this assay for blood? Initial studies, I think, were done in serum, but the performance characteristics of it in a blood sample, I think, need to be evaluated. We have some pilot data from our initial study where only 16 patients out of the 86 had urinary samples, kind of reflecting the difficulty of getting those samples. But of them, 5 had MTB bacteremia conferred by mycobacterial cultures, and the 4 that had negative mycobacterial cultures, 2 of them had AFB sputum, positive AFB sputum smears, and 3 out of 4 had abnormal chest X-rays suggestive for pulmonary TB. And also of note, 2 patients with non-tuberculous mycobacteria did not have a positive urinary LAM. So we know that it can be detected in septic patients. It needs to be studied further, but it's worth studying. Quickly, these data are from a manuscript that's currently under review. So we did a multivariate analysis looking at clinical predictors from our study of patients with MTB bacteremia versus not, and we found that male sex, tachycardia, with respect to HIV descriptors, having a low CD4 count and not being ARVs, which you would expect, as well as having a fever, low hemoglobin, and low sodium were independent predictors of MTB bacteremia. Looking at the performance characteristics by AUC curve, you can see we had 2 models. One was a full predictor model, which included those clinical correlates, and then compared that to just what would be expected to be good predictors for MTB bacteremia, the CD4 count and antiretroviral status. And there was a significant improvement using the full predictor model from an AUC of 0.74 to 0.85. We took these information using same methods as the Framingham risk score to develop a risk score for MTB bacteremia, and this is just showing how how sort of clinically useful for clinicians, but needs to be validated prospectively. With respect to biomarkers, we, in collaboration with colleagues from the University of Toronto, Kevin Kane and Conrad Lyles, who's now at the University of Washington, we evaluated some biomarkers, including ones in the immune inflammatory mediator pathway, vascular endothelial activation pathways, and coagulation pathways. But we did this not only to say that the biomarkers themselves are predictive of MTB bacteremia, but with reference to what we already know. So we used this tiered approach. So tier 1 are information that is free and available. So things like vital signs and chief complaint, which you can sort of get on exam. Tier 2 are ones that are also available and inexpensive, but not always taken. So these are sort of things like oxygen saturations, your basic CBC, and some electrolytes. And then finally, tier 3 are the biomarkers of interest. And so we looked at the incremental benefit of these biomarkers to the tiers 1 and tier 2. And as you can see from the orange line above, there is a significant improvement of AUC from 0.65 from tier 1 to 0.88. Just quickly, the black dots, we also did a in parallel analysis using a CART analysis, which ultimately showed that the same biomarkers, IP10, TREM, and ICAM, had the same incremental benefit. So, just in summary, MTB bacteremia is common in this population, particularly patients with severe sepsis, and we think it's an important phenotype to study. The clinical suspicion is low, and so determining ways to diagnose it early may save lives. And so our future directions, well, we developed this clinical risk score and have this information on the host biomarker, so we plan to prospectively validate this. We have funding for the next 4 years to enroll patients with severe sepsis in the same hospitals in Uganda. So I'll be nesting MTB bacteremia questions into that cohort. And then ultimately we'd like to develop a clinical algorithm which takes in consideration available MTB tests, these MTB bacteremia clinical risk score, and host biomarkers. In addition, sort of separately, really kind of taking a step back and understanding what the role of strain type is with respect to just virulence and outcome, but also with respect to sort of the community level and who are these patients? Patients with MTB bacteremia, are they sort of canaries in the coal mine? Can you go back and contact trace and find new types of patients that you wouldn't have found otherwise through the usual contact tracing? And then ultimately, we'd like to be able to do some sort of randomized controlled trial to determine management of sepsis with MTB bacteremia. Really, I think that's far down the line, but it's always good to think long term. So thank you to all of you, to colleagues from University of Virginia, University of Washington, and the folks back in Uganda.
Questions?
If you have bacteremia, do you have a substantial liver involvement? I mean, can you correlate that with the patient?
Yeah, so unfortunately, we don't have transaminases or liver enzymes in our previous studies, so I can't speak to that in our population. I mean, I think in sepsis, liver involvement is a end organ that's
Yeah, but
that's
if you
been
do
involved.
biopsies on the liver, on the autopsy, do you find more disease in the liver compared to those that don't have bacteremia?
I don't know the answer to that. I'm sorry. I don't know if anyone does.
I'm curious, in these people with severe sepsis and TB bacteremia, you have either data or any sense of the proportion of them that can actually take and tolerate an oral TB regimen?
What I don't know about tolerate. So like I said, 15% of the patients who had, so 15% of those 86 patients who had MTB bacteremia were treated empirically. So tolerate is one question which I can't answer. I can tell you outcome-wise that there was a non-significant improvement in survival of the patients who got treatment versus those who didn't.
Okay, your rates of TB bacteremia are like amazingly high, and I wonder a couple of things. Is it possible that, but it's hard for me to imagine, that it is necessarily contributing to the sepsis syndrome that you see in the same way that you have somebody with gram-negative sepsis. And that makes me wonder whether or not some of these people have incidental TB bacteremia and it's not contributing. There's some other cause of their sepsis syndrome, that whether that be some bacterial pathogen that your lab didn't pick up or something else. And what, because in HIV the rates of TB bacteremia, and what are those rates? I thought they were relatively high in non-symptomatic or non-septic patients. So,
yeah, no, that's a good question. It's one that comes up often. I can say to you that those patients, so we had mycobacterial cultures and aerobic cultures done on all patients, and so there was like 3% of the patients that had co-infection with or co-growth that happened in the mycobacterial and aerobic cultures, and the growth that happened in the aerobic cultures was usually staph epidermidis, so the contaminant. With respect to wait, sorry, the last thing.
I guess I'm just struggling to
Sorry.
Is it really leading to that sepsis
syndrome?
And is there...
So there's not great data about this. What I can say is that there was some preliminary data that was done in an outpatient setting prior to my study, or during our first study in the Rakai cohort. And so these were patients that were enrolled in an outpatient setting with fever. And they looked, so I think they enrolled 100 patients, and of them, 0 had MTB bacteremia. So they had mycobacterial blood cultures obtained on all these patients in addition to other blood cultures, and none of them grew out TB in the blood.
But if you look at people who have active tuberculosis and do blood cultures on it,
I thought 20%.
yeah, 25 to, the numbers quoted in these are older studies, but anywhere from 25 to 40% will have bacteremia.
And not be
with the higher levels of bacteremia being people who have extrapulmonary tuberculosis and HIV infection. So they do have high rates of bacteremia and don't have sepsis, so it's
But
not.
has that correlation been made, like that they don't have sepsis?
Most
So, I
of the
mean,
studies that
they're
looked at that
severely
were outpatient studies with inpatient studies with people who had active TB, but not necessarily ICU studies of people who were septic. But it's doing the opposite of what you did.
Sure,
You're generally
sure.
looking at all people with sepsis who had a blood culture drawn. These are people with active TB who are hospitalized or being treated for TB as an outpatient and had mycobacterial blood cultures drawn.
Yeah.
So it's a different patient population.
This question builds on the question asked just a moment ago about tolerating the TB drug. Especially as we're thinking about a prospective trial, I'm wondering, in addition to tolerating, you wonder in patients with sepsis or severe sepsis, how much gut absorption is there going to be of these drugs?
Yeah.
And would there be an inverse correlation maybe with sort of degree of lactic acidosis as a marker of poor gut perfusion and lack of response to the TB drugs for the mycobacteremia?
Yeah, no, that's a good thought. Yeah.
Okay, I think that's our last question.
Okay, so we have come to the end of the scientific part of this program. I want to thank all of the speakers who presented today. You all did a fantastic job. We really and now is more mingling. So we are going over to dinner.
Right across the street.
Which is apparently right across the street somewhere, but we will follow Brenda. And we hope that now, given you have a sense of what people are doing, you use this as an opportunity to build ties that will lead to future collaboration. So thank you very much.
So remember, we'll have dinner and